All right, so I think we're going to get started. It's a little after 5:30 now. I'm sure we'll have some people trickle in. I know it's kind of when people are getting out of work, so we'll give people some time. We're also having this taped on our YouTube channel, so if you miss anything or you forget something, or even if you want to watch it again, you'll have that opportunity. So just so you know who I am Kate Roach. I am the school to community counselor here. Some of you may know me as Kate Martin from last year. So tonight we're doing the Mental Health Parent Night. Manchester Mental Health with Tori and Katie here have been awesome and offered to come in and do this presentation for us. So with that, in your folders, there's a PowerPoint that they've gave us to hand out to you guys. And then behind that are just some resources that we've compiled for you guys to use. There's some adult resources, there's some adolescent resources, and then there's also a feedback form if anybody brought a pen. You can also fill it out online in the link that was in the email. So I'm going to hand it off to Tori and Katie.
All right, if I stand here, can people hear me okay? Do I need to stand closer? All right. Hi everyone, my name is Tori. I have my master's in social work. I'm currently working towards my licensure. I've been at the Mental Health Center now for almost 2 years. I've worked with the elderly, the dying, substance use, but by far my favorite population to work with is children and adolescents. Through the Mental Health Center, I've been trained in dialectical behavior therapy, so I work with at-risk kids who have unsafe behaviors and helping them safety plan. So.
I'm going to just try to stand here and then go so we're not like
moving back and forth.
I'm going to try. If you guys can't hear me, then I can move closer. But I'm Kate Glennon. I've been with the Mental Health Center for going on 3 years now. I have my master's in clinical mental health counseling. I have completed my supervision hours already. It's more like getting the exam. I haven't done that part yet. So, so I'm not licensed quite yet. But I am trained in dialectical behavior therapy as well as Tori, and I'm also trained in trauma-focused cognitive behavioral therapy, which is actually a good blend to have because a lot of kids who have trauma have the high risk, some of those self-harming behaviors. I have a history of working with youth with autism and also youth that have been on probation and kind of removed from their home. So then I started with the Mental Health Center, and this is a good setting for me. It's a blend of everybody. Questions. So as we do questions, because we have a mix of people, what I'm thinking is if people want to, they might put questions in the chat, and you guys might have questions as well. Maybe write down your questions, or if you do have questions, we can kind of save them for the end so we can kind of go through the presentation and then save questions for the very end, if that makes sense.
So just to give you kind of an overview of what we're going to do, I don't want to be talking at you for a very long time. I'm sure you've come with questions. So we're going to do kind of a brief overview of what anxiety and depression is. We're going to look at symptoms, and then big focus of the presentation is going to be on how you guys can help your kiddos. All right? All right, so right off the bat, how do we define anxiety? So this is more than just being nervous. Right now I'm standing in front of you and I'm very nervous. Doesn't mean I have anxiety. So this is excessive worry, excessive anxiety, persistently occurring more days than not for a period of 6 months. In this picture, you can see a girl, she's sitting outside of her classroom, right? She's nervous to go in, and so it's affecting her ability to be successful in school. So what anxiety does, it's going to affect multiple of those life domains, whether it be school, work, social, etc.
So as you can see here, there's a lot of similarities between stress and anxiety, and they're kind of blended together with these. So in the bubble is what we call those symptoms, and those are things to kind of look for when stress is occurring or anxiety is occurring. Stress, first off, is kind of that thing that tells us something is happening. So there can be good stress, things like buying a house, adopting a pet, having a baby. All those things are like positive things, but they develop stress within our bodies. Same thing for bad stress. So things like trying to study for a test or failing a test, getting ready, or having an argument in the home. I'm trying to think of some teenage negative things that could happen, like maybe a breakup with a boyfriend or girlfriend. So those are all negative forms of stress too. Again, all develop the same sort of physical symptoms telling us something is happening. I look at stress and anxiety as stress is like walking through a pricker bush, right? It's uncomfortable, it's that quick alert, something happened. But we also walked through it. So it's something that you can just like hopefully come past, where if you hit the pricker bush and then sit in the pricker bush, that's anxiety. It sticks with you. So that's kind of where you see the short term, and then anxiety is where it's like that stress is lingering. You don't have to know where it comes from either. I know I mentioned some examples of where stress comes from or anxiety comes from. A lot of times people don't know where it's coming from too. They just feel the symptoms and go, I don't know why I feel this way. And then for kids, they don't know how to put it into words either. This is another breakdown of the differences in the symptoms and the similarities. Like I said before, stress is a response to something, whereas anxiety is like this internal struggle, and it's persistent. Like what Tori was saying, it's like, I think she had said 6 months of just these ongoing feelings, where sometimes stress can be like you're running late for work and then it just goes away. I think the biggest thing to remember here is the differences, because some people experience stress and they label it as anxiety because that's just what we do, or the other way around. They think that anxiety is just quick stress and no big deal. So it's good to kind of figure out the difference between, and that's why I kind of found this chart to be helpful, so you can see the differences. Is this stress? Is this anxiety? How do we define the differences? Or it could be both too.
Right, and I think the important thing to remember is anxiety is going to affect those life domains. So it's going to affect schoolwork, it's going to affect their ability to socialize, it's going to affect their ability to work effectively, that sort of thing. So we have 5 types of anxiety listed up here. There are more. These are usually the ones that we see. Working with our kiddos. So generalized anxiety disorder, again, that's that 6-month or more period, worriness, restlessness, and it's affecting at least one domain of their life. And again, that persistent feeling. Panic disorder, so that is a panic attack followed by at least 1 month of that persistent worry. Someone who has panic disorder is going to avoid their triggers like the plague. Phobia is kind of interrelated with each other. So again, it's specific to a trigger. Sometimes it's crowds, sometimes it's insects for kids. And they're going to do anything at all costs to avoid that situation. And that's going to occur for at least 6 months persistently. Social anxiety, so this is more than just the kid who hangs out behind the parent's leg because they're nervous, right? This is your kid that is not only nervous in front of adults, but is nervous in front of other kids as well. Any sort of social situations, it could be eating in front of people, going to a social gathering, and again, they're going to do whatever they can to avoid that situation. And then the last one, unspecified anxiety disorder. This is the one that we usually commonly diagnose kids with because there's such a vast amount of symptoms out there that we define as anxiety, and so we usually like to take about a year to figure out, all right, is this truly anxiety that we're looking at, or are we looking at something else? So usually when kids come through our doors and they're experiencing anxiety, this is usually what they're diagnosed with.
And one thing to like kind of remember too with the unspecified anxiety is that hopefully once they hit 18, they shouldn't have an unspecified diagnosis either. So if you do have a child that has been diagnosed and they are 18 or older and they still have that unspecified, you want to kind of ask the questions, what is this truly, maybe from their medical provider or their therapist, because at that point, hopefully they're in adulthood now, and we've hopefully figured out truly what are those symptoms that is taking place here.
Thanks, Kate.
So this is a breakdown of symptoms of anxiety. When we say symptoms, these are behaviors. These are or things that they're experiencing. These are things that hopefully we're treating in therapy. So a lot of times we hear family members say, like, we need to get a neuropsych eval to see what's going on, to get answers. Okay, that's helpful. And we also want to be targeting these to help them decrease, because these things are happening for our child or children. And these are the things that are kind of causing them to not go to school or not go to work or not hang out with friends that they were hanging out with or whatever. These are the things that are interfering with those life domains. A lot of times when we're reading these symptoms, we may think, oh, it's just ADHD, oh, it's just oppositional defiant disorder, which it could be, but we also want to remember that it could also be anxiety, and I think sometimes anxiety is like hidden underneath the rug, because when we see, let's say, like the avoidance, we're like, if kids are saying, I don't know, we almost think that that's like being a pain in the butt, like, you do know, tell me, but it truly could be, I don't know how to put anything into words with what I'm experiencing. We definitely in therapy get the I don't knows, and it's like, you would make my job so much easier if you knew, but and the psychological, so the ones in the middle are the hardest to notice, because we see the ones on the right all the time. So there's the ones that we're like, oh, okay, let's figure out what that is, but then we're missing all these other ones. Sometimes you can notice the physical within your child or children, but the psychological is truly where you have to ask the questions if that's what they're experiencing.
All right, this is a simple slide. I'm simply going to just read it to you guys. Hopefully it can just kind of resonate with you. So anxious children are often overly tense or uptight. Some may seek a lot of reassurance, and their worries may interfere with activities. Parents should not dismiss their child's fears, because anxious children may also be quiet, compliant, and eager to please. Their difficulties may be missed. Parents should be alert to the signs of severe anxiety so they can intervene early to prevent complications. So basically from that slide that Kate was talking about, what we're seeing on the outside doesn't mean that's what's happening internally. So the next slide we go to, I'll kind of talk about how do we get that internal stuff to come out so we can help. All right, so on your left, there are questions, and on the right, we kind of gave you some tips. So you're in the hallway and someone asks you, hey, how's it going? How are you? How do you usually respond?
Great.
Good, great, right? Right? And our kids are going to respond the same way. So it doesn't give us anything to go off of, right? Okay, great, I'm glad you're feeling good. But something could be going on internally. So changing your wording. Hey, how are you feeling? You can say, how was your day today? How are you feeling? Right? Use that cue word, feeling. Then you have the kids that still say, good, right? Then you can use that specific language of, okay, are you feeling happy today? Are you feeling sad today? I mean, the basic words, sad, mad, happy. You can get into anxious, all of that if you want to, and they might roll your eyes at you. I speak from experience, but sometimes we just don't have the words to express ourselves. So if we can, model that language, which we have over on the right here, it can help them out. So let's say they finally are like, yeah, I'm feeling down today. I'm not feeling like myself. This is your time to validate. So that's on the right there. Validating does not mean fixing. Sometimes you can't fix it. The most powerful thing that you can do for your child is to say, I hear you, I understand. Sometimes when we immediately go to fixing, it can feel dismissive, right? So, hey, I'm sorry you're feeling that way. I understand, school can be really overwhelming or whatever the situation that's going on. And you can ask, is there anything I can do to help, right? If they're still like, I'm not really sure, that's when you can say, all right, well, I'm here if you need me. Come talk to me. Keep that line of communication open. Okay, yes. So then we have the second bullet, talks about the behavioral stuff. So that's kind of what Kate was going off of kids can present so differently than what they're experiencing internally. You have a kid that's really irritable, talking back, just you can't seem to get through to them, ask them, hey, is something going on, right? And they might say, no, nothing. That's when you can ask specifically about those feelings, about those symptoms, right? Are you feeling like your mind is racing? Are you feeling lonely? Are you feeling restless? Again, modeling that language for them so that they can attach to something. Because like Kate was saying, sometimes they don't even know what they're feeling. And when you start giving those words, kind of this light bulb goes off in them, and they're like, yes, that's the word for it. That's what I'm experiencing. So again, you would validate them. So then on the right here, we have modeling language. So yes, you guys are the experts of your children, and yet there are times that you still don't know how they're feeling. So we try to stay away from saying, you are feeling this way, right? We want them to say, I feel this way. Give them the opportunity to tell you how they're feeling. Even though you might know, you might be 100% spot on, but still giving them that opportunity, that space, and, basically saying in between the lines of, hey, it's all right. Tell me how you're feeling. Doesn't matter what you're going to say. I'm going to be here for you, right? Any questions on that?
So this is another form of kind of a skill that you can use with your child where you look at intensity of emotions. This is a subjective units of distress scale. You can find like a whole bunch of these on Google, honestly. You might see these at the doctor's office, but I think they're helpful when it comes to if they do identify the emotion they're feeling or that symptom that they're feeling, to have them rate it, because that's where you're going to start to figure out, or they can kind of work with you to figure out at what point is it preventing them from doing something. So at what point are you not going to be able to go to school? At what point are you not going to be able to do your homework? Or at what point are you not going to be able to go to work? Things like that. Because a lot of times the kids can tell you, like, if I reach an 8, then I'm not going to be going. And so that's where it's easy for us then, as support people, can like, okay, well, if you're at an 8 now, what can I do to help? What can be helpful for us to get to, and you don't want to go, how can we get to a 0? Because that's really far away from 8, but even just a little bit lower, like, all right, at what point can you be able to do something? Because your anxiety isn't just going to disappear. Remember, it lingers. You're sitting in that pricker bush, so it's not going to disappear completely, but how can it go down? These are some techniques that we're actually going to go into a couple, but these are some techniques that do help with anxiety or getting those symptoms down a little bit. Breathing techniques, there's a whole bunch of them. I think we're going to talk about square breathing because that seems to be like a super basic, easy one that we teach. But there's a whole bunch of them that you can do. For younger kids, I know that we're in high school, so it's teenagers, but for younger kids, if you Google alpha breaths, that's a fun one to work on breathing. It goes through the alphabet with a bunch of like animals that you like, they act out an animal and they breathe at the same time, which is kind of cute. Pleasant distractions, so something they enjoy doing could be helpful. We kind of run into this where a lot of times kids revert to video games and they say that's my pleasant distraction, but then they stay stuck on that. So just be mindful of, is this a coping skill helping them decrease that anxiety, or are they just kind of relying on this one thing to help them? Listening to music seems to be a common one. Mindfulness apps on the phone, there's a whole bunch of them. I know there's the Calm app. For our DBT consult group, we like to do the Mesmerize app. You do eventually have to pay for it. I do the cheap way of downloading the app, deleting it, and downloading it again. So that's just what I do. But you can pay for it. It's not super expensive. But that one is actually like a kaleidoscope and walks you through like that guided imagery, and that can help with also sleep too. My husband uses it for sleep, and I don't know, he's not in the clinical field, so.
All right, so some more coping skills for you. Oh, I didn't even realize that the number counts down. That's cool. So square breathing. Probably someone in some time in your life has told you, just breathe, just breathe. I don't want to breathe, and you get frustrated with them. How am I supposed to breathe? I'm so overwhelmed right now. There's science behind it though. When you're taking deep breaths, you're slowing your heart rate down. By slowing your heart rate down, you're slowing your body down. It's biological, so it does work. Kids will say it doesn't. It does. So when a kid tells me that it doesn't work, it means that their mind is going a mile a minute. They can't focus on the one thing that we're asking them to do, is breathe, right? So what I will try to have them do is, all right, focus solely on your breathing. As your mind starts to wander again, bring it back to your breath. So square breathing. Breathe in for 4, hold for 4, breathe out for 4, hold for 4, and just keep going. I have some kids that'll listen to music while they do it, because again, it's keeping their mind busy. Whatever you can do to get them to solely focus on the breathing itself. That's the mindfulness component. And then the other skill that I'm talking about is rosebud thorn. So this is a conversation tool. So back a couple slides ago when I was talking about connecting with your child after the school day, this can actually be a really great technique. It can seem very adolescent-like, but it breaks it down into kind of a high-low scenario. So you're asking your thorn, what was challenging today? What was the most challenging part of your day? The bud can be, this can kind of change depending on the child, but I usually will ask, what went well today? What did you succeed in? What did you learn? And then the rose, it says succeed up here, but I take any positive. I had a rockin' sandwich at lunch. Awesome, great. Finding any sort of positive from their day to latch onto. So it's making it descriptive and really having them focus on the day, getting them away from saying, yeah, my day was good, right? You're asking specific questions. So I love that one. And I use that from age 4 all the way up to age 18, so.
And some of these, like the key thing, and I'll go over the other two, the key thing about these is like where can they use these coping skills too, because the main mission is for them to develop a tool, I call it a toolbox. So again, they're not relying on just that one thing. They need more than that. Because I always say to my patients, like, okay, that is helpful, like listening to music is helpful, but then when you're in class trying to like learn something, you're not gonna have your earbuds in the whole time. I know some accommodations they can, but they need more than just relying on that one thing. So the breathing technique can literally be done anywhere. The rosebud and thorn is like more of that conversation-based skill. The mindfulness 5, 4, 3, 2, 1, that's actually really useful also for kids that have panic attacks, to try to help them prevent that from happening, because you're catching their attention on something else. So 5, 4, 3, 2, 1 is kind of easy to remember, but you don't have to go in that order. The biggest thing here is just your senses. What are some things that you can see? You could just simply ask that. Things that you can smell, things that you can taste. A lot of times they'll argue, I'm not eating anything, I can't taste anything. So if they have something in front of them like water, they can even just feel the sensation of the water in their mouth without swallowing it immediately. If they don't have any water or anything to drink, I always challenge them. There must be some sort of taste in your mouth right now, or sensation, or just feeling the inside of your mouth that you can do. So again, this one is really useful for either helping those panic attacks from happening. It can be even just like if you're at that 8, you need to come down, let's practice this together. That is something that is helpful because kids don't have that frontal lobe to stop and go, oh, I need to use this to help myself. So they may need that modeled for them, or let's do this together, or what can I help you with? The progressive muscle relaxation can also kind of be done everywhere. This one shows laying down because it is actually useful for sleep, but you can do it sitting. The biggest thing about this is when a person is stressed or anxious, they have tension in their muscles somewhere without you realizing you have it. And then eventually, like as we get older, those knots develop in our back and we're like, how did that happen? Oh, I probably know why. So this is a good technique to, again, decrease stress, decrease anxiety, but the goal here is starting from either head and going down to toe, or you can do it the other way around, toes to head. You're gonna tense each muscle group for however long you can handle it for, and then relax it. And you're focusing on each muscle group slowly, so you're not doing them all together, but you're doing them one at a time. With younger kids, you can make this super fun too. Like, so for like the belly, I'll be like, pretend an elephant is coming and they're gonna step on your stomach. You gotta tighten your stomach so it doesn't hurt. So you can kind of make it fun in a way. But I know with my teenagers, I've definitely just like, I've actually laid down in the grass with them to like walk them through how they would do it. And also I'm doing it with them because that is helpful when they're seeing somebody else do it, because otherwise they're not gonna wanna do it probably by themselves.
Alrighty, so we're going to move right into depression now. So again, kind of same idea. We're going to go over the overview, symptoms, and then again, what can caregivers do to help their kids out. So what is depression? So we have persistent feelings of sadness, hopelessness, loneliness, and the words that I want you to focus on here is lose interest in activities they once enjoyed. So persistent and that losing of interest. We all have days, off days, when we're feeling down, we're feeling sad, and sometimes it's hard to latch on to whether or not this is just a bad day or we're having multiple bad days. So a cue for me is looking at, a kid's interest. So let's say Sally in the tunnel loves to hang out with her friends. Like, it is like her prime thing she does all the time, and now she's isolating more often than not. All right, that's a cue right there that something's going on. This is a girl who loves to hang out with her friends and she's not doing it anymore.
So this is a breakdown of the symptoms of depression again. I know Tori did a quick overview of kind of the diagnosis and things like that, but this is a breakdown of each symptom, and we kind of look for, again, persistence. How long is this happening for, and how many? Because if it's just one and it was just for a week, that might be a little bit different than the full depression. So just asking the questions. I know us clinicians, we assess this all the time with our patients, so we'll use the patient health questionnaire in teenagers, or what we call the patient health questionnaire 9, which is like for the 18 and older. So we have some of those still. So we do that, which asks about these symptoms and whether it's like every day or more than half the days or just sometimes or not at all. And when they're starting to say every day for all of them, the number increases in the assessment or the scale, which then tells us, okay, yeah, this is depression. The other one we use is the hope scale. So kind of just like future thinking, which doesn't typically happen when somebody's feeling depressed because they're just in that moment of this doesn't feel so good. But yeah, so sorry, I was like, so those are scales we use as clinicians, but then as parents or guardians, just asking specific questions of these things. If you're worried, you could ask specifically, are you experiencing this? If they say yes, the next question might be how often? Every day, once in a while. One of the questions in the assessment says more than half the days, and they don't really know what that means. So I have to break it down. Okay, well, there's 7 days in a week. So on that average, how many days a week are you feeling this way? That seems to be more helpful.
Alrighty, so it might be hard to read, but this is kind of going over that idea that what we're seeing externally, it can be completely different than what's going on internally. The depressed child is going to look unmotivated and irritable most of the time. But there are a lot of other words that we have here. You've probably thought about them like, man, they're acting this way, or man, they're acting that way. That's when I would encourage you to ask them these. Are you feeling these words? Are you feeling lonely? Are you feeling judged? Are you feeling scared? Are you feeling angry? Right? Using those feeling words that they can attach on to.
Tori, I think you have a question.
Yes.
Sorry, Tori.
I always kind of fear that if I ask those questions, I'm going to be putting the language and the ideas in their head, and then they're going to have the problem. Is that like silly of me, or is that a real issue?
I'll go and then Kate can go. It's very natural to feel that way. It's the same kind of idea when we're talking about suicidal ideation. There's like this fear that if we talk about it, it's going to plant the idea in their head and they're going to feel suicidal. Those thoughts are occurring already. By you giving them the words, we're giving them the language to be able to express themselves. That feeling is happening internally, and they're just not knowing how to identify with it. So it's completely natural, because then you start giving them the language and all of a sudden it's like Pandora's box and they're like, oh my gosh, it's all these things that I'm feeling. And it can be really overwhelming, and also it can honestly be very beautiful for them to be able to express themselves in that way. So yes, it's very natural to feel that way.
I was going to say that similar thing where, as a parent, we want to like protect our kid. I only have a 10-month-old, so I am not even at the teenage stage yet. But it's that it's that fear of like, I want to protect my kid and fix my kid, and if I do this, am I going to hurt them? And I think like that's where we're kind of getting to this point where, again, you guys are the experts of your kids because you spend the most time with them and you're the ones that raise them. We're giving some other ideas that questions are okay and language is okay, because they may not even know what that is because they've never been taught it before. So I know we're going to eventually, after the slide, hit on a slide about suicide and how we bring that up with our kids, which can be kind of an uncomfortable topic, I think, sometimes. But depression doesn't always have to be leading to suicide either. A kid can be depressed without having those thoughts, or they can be depressed and have those thoughts. So it's good to kind of ask specifically, what are they experiencing? But it is normal to feel that way of like, I'm worried that they're going to learn something bad and they shouldn't be learning this. But again, open dialogue is really key to a healthy relationship in general.
Yeah, absolutely. And not only are you giving them language, so let's say you are worried they're just latching onto this word and they don't even know what it means. That's when you can ask about the symptoms. You feeling like you have a tight chest? Are you feeling like you're sweating a lot? Or ask about those like biological symptoms or the behavioral stuff that you can see on the outside to try to narrow it down. So how can caregivers help? So some more coping skills for you. Some of them are similar to anxiety. I'll read through them kind of briefly, and then I'll kind of talk about my favorite one. So we have deep breathing, taking a break, going for a walk, listening to music, drawing, exercising, talking to a trusted adult, spending time in nature. All of these things have one thing in common. It's getting them out of their environment that they're cocooning in, right? So sometimes it's their bedroom, sometimes it's like the basement, whatever it is, and they're cocooning in there. And by having them come out of their environment, I forget the wording that I usually say to my kids, but basically we're getting them out of their environment, we're getting them out of their head. And so I always suggest, like, if a kid's in their bedroom all the time, just have them sit in the living room. Like, just get them to change their view, change their perspective, because it's so easy to kind of sit in that funk. I love going outside. Going for a walk is probably one of my favorite things to just clear my head. But I think the key here is getting them out of that cocoon that they're in.
And I think another thing to add to here is if you say, do you want to somebody who's depressed, they're going to say no, probably. So it's really helpful to be like, let's go do this. But also try not to be, I'm overly puffy sometimes, so I'm mindful that I can try to match them a little bit. How about we go do this? Let's go. A drive is also, unfortunately with the gas prices, be careful. But a drive is also a really good one because then you're not face to face with them. You're sitting next to them and they feel less intimidated, but then they get that one-on-one time. So even if you're picking them up from like work or school or something, take advantage of that one-on-one time, even if it's a 3-minute drive. It's a good opportunity to try to get that conversation out and in private. But yeah, all these things, if you try to say, let's go do all these at once, that might be overwhelming. So maybe picking just one a day or one a week to start slowly can be helpful.
Yeah,
Sorry.
no, that was good. It triggered something in me as well. The thing to remember too is they're going to use these skills and they're not going to automatically feel better. They might say, I don't know, that didn't really do anything. It's about being consistent with it, right? I have one kid, every time I'm like, all right, get your shoes on, let's go, let's get that walk in, right? And now every time that I come to that household, he gets his shoes on and he's ready to go. That unmotivated kid now has a regimen and he's motivated and he goes on a walk with me every single session, right? So it's about consistency, being persistent with it, but also not overwhelming them with coping skills.
So this is a slide I was saying that this may be an uncomfortable slide or uncomfortable conversation to have. It is also very key and something very important to kind of review. Because we're both in DBT, so when we say those like high-risk behaviors, a lot of times it's the suicidal ideations and the self-harming behavior that we're trying to work with our patients and the patient's family on. So a lot of times, because we're asking specifically those questions as clinicians, family members feel like they don't or aren't allowed to, or they aren't sure if they should. You can, and it's important to. So if you are truly worried about your child, you can specifically ask these questions. And so if you're getting, what I was trying to do is like the flow, because we use what's called the Columbia Suicide Screening Scale, which is like, in the past month, have you wished you were dead or wish you'd go to sleep but not wake up, is the first question we ask them. So again, it seems pretty like uncomfortable topic that you would be nervous about introducing. However, if they are experiencing it and it's never getting asked, you don't know what they're going through. Again, that internal stuff is so hard because you want to get that out somehow, and the only way to is if you ask specifically those questions. You know, do you feel safe at home? Do you feel safe at school? Do you feel safe at work? And then really you go specific, more specific, more specific. You know, do you have thoughts of hurting yourself? If they say yes, okay, what would you use? Because then if they tell you, then you can kind of be prepared, you know. Sometimes they'll tell you, sometimes they may be like, I don't know. If they tell you yes, and I would use this, they have more of a concrete plan than I don't know, I just have this thought. So as you get answers and more detailed answers, then you know at what risk they are. I know a big question here is if they're saying yes to these questions, what does this lead to? Do I just take my kid to the emergency room every time? It doesn't have to be that way, because nobody wants to be sitting in an emergency room with their kid for hours on end until they're seen. And then if they are seen and assessed and they have to wait for a bed at Hampstead, because that's our option here in New Hampshire, it's like now they're waiting even longer. So it is very uncomfortable, but again, it doesn't always have to lead that way. It depends on how specific they are with their plan of, are they going to hurt themselves? Are they going to kill themselves? Do they have this plan? If they don't have a specific plan, then it kind of tells you, okay, like they're not really there yet. But if they do, there's options, right? You can take your kid to the emergency room if you feel like that's the right decision as a parent. You can make that decision to go. Or if they do have a therapist, that person is the person to call. We are going to give you a phone number too, but in the state of New Hampshire, we have what's called rapid response, which is 24/7 of a support team. If our patients call that rapid response number, we actually get emailed right after that our patient called, so then we can check in with them when we're back. So that is another support to use if you're, looking for support as a parent when you're home, because not everybody's in therapy, so some people are like, what do? I don't know what to do. I know that, like we said, questions at the end, but any questions, thoughts, comments on this slide?
So this is just kind of going into more depth of what Kate was bringing up. So we kind of have these 6 blocks as kind of a step-by-step process, or maybe even like a triage system that you can do with your child. So first thing is you are increasing awareness and understanding. Great job. You guys are here. You're already halfway there, right? You're increasing your awareness about what to look for, what symptoms, what to ask, that sort of thing, and now just put it into practice. And then, again, you guys are the experts of your children, so you kind of know when they're off, right? So, again, being more aware of those external behaviors that you're seeing. So then checking in, this is another slide that I had done. So asking, how are you feeling today, instead of how are you, or how is your day? Asking about specific feelings, asking about specific symptoms, however in depth you want to go. Now let's say you're not sure, they're not really giving you a clear answer. If you don't know, ask, right? There's nothing telling us that we can't just ask what's on our mind. You get that gut feeling, you want to know more about what they're talking about, just ask them. So let's say, I have an example here. The child seems to be struggling expressing themselves, right? They've kind of given you emotion, they haven't really been able to attach to symptoms. Keep going until you can find something. If they're still unsure, right, and you've already tried to discuss symptoms, you can access mental health care, right? So that rapid access point number that we're going to give you at the end, again, it's 24/7, 365. Get them talking to someone. They're probably going to ask very similar questions, and it just might be enough to get them to answer, right? And then from there, they're going to assess whether or not your child's at risk, right? Are they having urges to self-harm? Are they having thoughts that they want to hurt themselves or kill themselves, right? If that's the case, they're going to come out and they're going to assess your child on site. And they're going to do a safety plan. So that's kind of that next step. We wrote these 5 and 6 because you can also safety plan with your child. It doesn't have to be just the mental health care provider. So safety planning. Asking the child, all right, how are we going to keep you safe, right? How am I going to keep you safe until a rapid access point comes? How am I going to keep you safe until we're connected to a therapist? What are we going to do? If they're like, I'm not really sure, well then you kind of look into what are the behaviors. Are they having urges to self-harm? Okay, maybe we need to limit access to sharps, right? Scissors, knives, tacks, that sort of thing. If they're having suicidal ideation, right? Looking at weapons in the home, right? We want to limit access as much as possible, medications, that sort of thing. And mental health providers will be able to help you with those options as well, and making sure that it's specific to your child. And then I always like adding this into my safety plans is who are we going to outreach when we're feeling this way? Whether it be a friend, a parent, a teacher, your mental health provider, right? To just talk. It might not be about the situation itself and what you're feeling, but just to talk to somebody, right? Getting yourself out of that cocoon that you're in, out of that headspace. And then we talk about, all right, who are your people that you can say, I'm having an urge to hurt myself, right? And we talk about those people, and then we even do a specific plan of what are we going to say to these people when we're feeling this way. So safety plans can be very specific to your child, and hopefully they are.
And the last thing on a safety plan too that we ask is like, what are those quality of life things? What is like keeping you here? And you try to have more than just one thing. Okay, so then I'm a very direct person. So if you're not here, then these people, like if they have a hamster or dog, then these things are not going to get taken care of, by the way. So we need you here, is language I always use. But again, not a fun conversation to be having, just something that is important.
And the idea here is that we're talking about it. I think for so long this has been a taboo subject. And just like that slide said about anxious children who suffer in silence, it's the same thing with depression. It's the same thing with any mental health diagnosis. Many go suffering in silence. So if we can give that line of communication and we're just honest and open about it and we're upfront, we're more likely to get someone to latch on and hold, right, for that support.
One thing we didn't mention too is the suicide rate didn't increase during that pandemic. I know a lot of people thought that it did. What did increase was more people looking for help and seeking help. So I did want to kind of make that known because I think a lot of times like people were like, oh, the suicide rate increased, but the numbers actually didn't change. It was just that more people were getting help. I do know that the pandemic was really stressful, is really stressful and hard on our kids. So it is something that I'm not ignoring that happened. I'm just saying, like, just to point out that we did look at the numbers and they didn't change, which was very interesting because a lot of people thought that they did. So this is the phone number if you have it in your sheet. So this is a good number to have. Actually, what I did with one of my patients today was I actually had them put it on their wall, tape it on their wall in their bedroom, because a lot of kids nowadays have cell phones. So if they are, it's like 3 in the morning and they're struggling and they just want to talk to somebody, they can call. So this is for anybody. They don't have to be in our system at all. This is anybody in the state of New Hampshire. It's actually kind of a new thing, so it'd be interesting for you guys to take a look. If you just Google rapid response, there's like a ton of resources online about how it developed, because we were noticing that a lot of people needed more help 24/7 than just the typical Monday through Friday help. Questions?
Yeah, when COVID started, they had the online school for, I don't know, 2-3 months. I noticed my son had a tough time with that. Did you notice that a lot of kids had a tough time with that? Because when school started again, it just snapped right on. It was back to normal. But I noticed a big difference when there was a home school.
Yeah, well, and we just said too, right, like take your kids out if they're feeling depressed. Well, the
Yeah, well-
pandemic was like, they couldn't. So it was like, how do we be creative and doing things if we're not allowed to be around other people? I mean, other people is a big thing that helps us feel better, just as a people. Like, we lean on other people for support, and that social interaction feels good.
But
And now all of a
that's-
sudden, we're not allowed to.
I'm sorry. What helped him a lot was he was online playing games with his friends. He had
Mhm.
three good friends.
Yep.
And I realized, hey, you guys have to get together. You know, try to have fun, do something. But there was a big, there was a problem.
Yeah, that was, I think, across the board. Yeah.
We've been looking for someone over our daughter for 8 months, and I can't find anybody that has an opening. And that's the worst part, is she knows she needs help, we know she needs help. And nobody has openings. I'm gonna definitely call the resources that you're giving. I hope that they'll have an opening, but I think that's the most difficult part, because I can watch the anxiety get out of control. And when she feels like she's failing something, she'll get depressed. And try to sleep all day.
Yes.
You know, it's just trying to manage this when you can't find anyone to work with us.
Yeah, and I know that our wait list is ridiculous. I'll be honest, like it is. And because we serve Londonderry, so I know if people call for an intake, they're waiting for the intake. Once they get the intake, then they're stuck with the intake clinician until they're set up with a clinician, which is even longer. So it is a tough thing. One thing I do try to recommend, I mean, again, like not trying to lean on the school district, but if they do have an IEP, trying to request as many IEP progress meetings as you want as a parent, because you can, and talking about what other resources they can have during the school day. Is their school day too much on their plate? Is it too little? Like trying to figure out if there's something during the day too that they can adjust. But I hear you.
Well, I know that she isn't on IEP. So, and Londonderry's been absolutely amazing.
Yeah.
They've been wonderful.
Yeah.
But some of it is, you know, is that internal thing where our kid has this desire to be absolutely perfect across the board,
Yeah.
which I don't know where the hell it came from. Other people good. Other people have this fun, and it's horrible, because
Yeah.
we've never said you have to earn straight A's to be perfect.
Right.
I'm like, please fail at something. It's so good to see you come up with that.
So this might actually be a nice resource for her, right? Especially when we're really up in the clouds and we're unraveling, right? Calling this number, it's free for you. I also know that, and you can call the mental health center. We have an open access point number, or open access point slot. That's kind of like a first come, first serve. We have people waiting in lines, and it's for intakes. Sometimes can get people in earlier, but it's sometimes a shot in the dark. And there was one other thing that I wanted to say.
We also do intakes here at the school. We have a person that works with Londonderry families to do the intakes here at school, if that's helpful.
And being a Londonderry alumni myself, my guidance counselor was my saving grace. I know that that's not fully what they're trained in, but it was someone to talk to. It was someone to check in with. It was a face that I knew was there for me. So please have them go to their houses. I know that the guidance counselors are awesome. I've worked with them now kind of on the other end, kind of full circle now, and they're still as awesome as they were when I was back in high school. Yeah.
I have 2 questions that I wrote down. Panic attacks, you mentioned panic disorder. Can you have a panic attack with anxiety and not have it be a full-blown diagnosed panic disorder?
Yes.
Yes. Okay. And the other question is, you talk a lot about them not really having the words. Is that true even in upper teen age range?
Yeah, so who are they learning their language from?
Me and their peers.
Peers, everyone, right? I know I grew up without the language because it's just, we didn't talk about it. And now the generation's changing. It's really starting with this generation of bringing that language in. Think about your own childhood or these conversations that you were having, right? It's going to look a little bit different now. So yeah, I mean, some kids really just don't have the words for it because they just haven't been around it. Like I've been working with some of the teachers here, and it sounds like they're trying to incorporate the language into the education as well, which is awesome, getting it from home, getting it from school, best of both worlds there. So yeah, it is about that kind of exposure and bringing it out to them.
Yeah, because one of the, like, about brain development, your brain actually isn't fully developed until mid-20s. But a big thing that's, like, ignored is if they have any sort of trauma, it's actually delayed. So what happens is, like, the middle part of your brain is that emotion, where emotions come from. That's developed, because back here is developed first. So it kind of goes from, like, the brainstem all the way, that's how it's developed. And because of that, this part of our brain, the frontal lobe, is responsible for that stop response. So, like, that's why kids are so impulsive sometimes, is because they don't have that stop. They don't know how to organize. They don't know how to plan. But the emotions come out. That's why babies cry so often. Because that's there. They know how to react to the emotion. It's there. They just don't know what emotion that is or how to put it into words. So it is like modeling that. I do that in therapy sometimes. If I have somebody who, let's say, is not engaging with me, I'll say, I'm feeling kind of frustrated because I feel like you're holding a wall up somehow, and I don't know. I'm just letting you know that's how I feel. So I try to put that into words as much as I can. I know you had your hand raised. Yeah.
I think it's basically COVID, but the not being able to get a professional in the mental health industry right now. We had a pretty serious issue with one of our boys a month ago, and to the point where we're scared shitless. And then you find out there's nobody you can get to talk to them. And Ada told me many times I should set up an appointment and get them seeing somebody, but I think if your kid's having trouble, you want them to have a relationship in case the trouble gets real bad.
Mm-hmm. Yeah, and you can, I mean, any of you guys who are not in our mental health center, you can call to schedule an intake. I'm just saying, I know that, like, there might be a wait.
It's the wait.
And also, once they do have that intake, they at least have a clinician with them that will be checking in at least once a month to, like, and also is available to them more than that. Because I think sometimes our intake clinicians are acting as, like, clinicians on a team to themselves, because we just, we have 3 different levels of care. So we have level 2, level 3, which we're both on, and level 4, which just is more about what is their need. Level 4 is weekly because they have a smaller caseload. They're supposed to be at 15. Most of them are at 30 right now because we're tacking on as many as we can. And for level 3, we're every other week. So most of the time, if we're working 4 days a week, they're 4 10-hour days. 40 is our number we're supposed to have. Most of our clinicians have more than 40. So just to kind of give you a picture of how our setup is, I know there's CLM in Derry. I don't know what their wait list looks like.
It won't take Londonderry.
I was going to say, I don't think that they do because we serve Londonderry. I know that. That's why I was like, I don't know. And then also the other barriers, most of that our kids have, New Hampshire Healthy Families or WellSense, which private practice won't accept, which is kind of like that unfortunate thing too. So it's all about insurance and money, which try and find a place, but I always recommend like Googling or Psychology Today to see calling. I also recommend being a pain in the butt as a parent and calling as many times as you can.
That squeaky wheel that you can't get rid of.
We're going to call it PCP possibly, either care call PCP.
Yeah.
Absolutely. Yeah, we have lots of kids who will outreach their pediatrician and kind of start there, sometimes even start medication through them. And then that kind of transitions as they get connected to a mental health provider. And then usually, more often than not, we take over medication, so it's all under house. I did want to go back, the green sweater, you had brought up language, and I just thought of it. Using your own language to express how you're feeling too is going to be helpful, because we're not statues. We have feelings too, we have emotions too, and that's also going to break that barrier between you and your child if you're like, I have bad days too. Especially if they're struggling to really get out what they're feeling, saying, I struggle too. When I'm feeling irritable and grouchy, it probably means I'm overwhelmed. Do you experience the same thing, right? It can be both a connecting point for you guys and also letting them know, like, it's really okay to open up. Sorry,
No, that's good. I was going to say, our primary care doctor mentioned to me once, it made me think of like how we're feeling. Like whenever my daughter's anxious, my anxiety goes through the roof, right? So he once said, we're only as happy as our saddest child. And it really resonates with me. So I'm wondering, is there any support for us?
Yeah.
It's really hard.
Absolutely. So, besides getting your own clinician, like for us, we do family work, right? So we're doing individual sessions, we're doing family sessions, we're doing parent-only sessions, because that child is part of a family. You guys are a unit. You're all in it together. So it's very important. Yeah. I actually always recommend to parents to seek out to have their own sounding board, so that they have a place to kind of unpack things.
There's also a resource, the Upper Londonderry has some parent groups for parents that are trying to manage their own children's anxiety, depression, whatever their mental health is, so that way they are having that support as well. And talking to other parents, like what works for one parent may work for another, but you may not know because you haven't had that conversation.
Yep.
And again, unfortunately, like if you're not within our agency, this won't be helpful. But we do, like for example, coming up in April, we're doing a match conduct group just for parents, for kids that have conduct-like behaviors. I know this isn't really super related to what we're talking about, but we try to do a lot of parent-only groups too. And I think that one would be, sometimes we do it virtually, and sometimes we're doing it in person. I know the Dbt Group, we run 2 groups a year, and that one we include the parents. So it's a 2-hour group, and the parents will meet with one clinician and the kids will meet with one clinician. Then the second hour we all come together and work on skills. So that's how we do our Dbt group, which is also kind of helpful. But again, trying to get into the program is the first frustrating step, I'm sure. It's frustrating for us too, because we feel really bad when we finally get somebody on our caseload and we realize our intake was forever ago. And we're like, oh, like you've been waiting for so long. And sometimes we don't even hear from those people because they've been waiting for so long, and then we can't get a hold of them. So it's like, we do feel bad.
Sometimes what I recommend to families too is if you can get on the list for Manchester Mental Health, and you can keep looking, like as you're on that list. So just because you're on one list doesn't mean you can't also continue to look and have your name in other places too. That can help too.
Absolutely. And using skills together. I think Kate kind of mentioned this, but like, hey, let's go for a walk. It could be for them, and it could also be for you too a little bit. If anything, that's going to be even a greater connecting point of, you know what, I'm feeling a little lousy myself. Why don't we go do something? Let's go for a drive, right? Again, another connecting point for you to use skills, for them to use skills, and for you guys to connect.
Yeah, you mentioned this session was for parents. Do you do any type of session like this for the kids?
For like this training, you mean?
Like an overview or like similar, you talk about the language.
Mm-hmm.
Do you do anything like this for
We haven't yet, but
I
I,
think the room would be in.
But virtually, it might not.
right, yeah,
Virtually,
Yeah.
it might not.
yeah.
No, it's a great suggestion.
Yeah.
Yeah.
Good point.
Yeah.
So kind of just to piggyback, I was just thinking that too, just having like my daughter here, just kind of listen.
Oh.
My thing is, my daughter kind of takes on a lot of her friends' anxieties and stressors and everything. So having like the children kind of be able to have
Yeah.
their language together,
Yeah.
maybe might also kind of,
Yeah.
bring more awareness and, positive reaction, I guess I would say. It's one thing for parents to say, hey, open up and try to chat, but when it's two friends.
Right.
And they're kind of venting, or they're,
Yeah.
frustrated about this, or whatever the case may be, it causes them anxiety, depression, maybe having them kind of be able to have the language to talk to each other.
Yeah.
I mean, it's one thing to support your friends and like,
Right.
to each other, but it's more or less to kind of get your friend out of that, their head, basically.
Right.
And that's what I just kind of took it now, because my daughter, like I said, she has her own, but then she has her friends that kind of feed off each other. And, it'd be nice to have them be able to say, hey, like, I didn't learn this in therapy, but, these are kind of languages. And, and with the school, I know the parents, they're obviously great to communicate with, but having something like this where the kids can kind of, take bits and pieces and learn kind of from it.
Yeah, we'll definitely bring it back. Yeah, great suggestion.
So we are planning to host a couple of events on campus that are catered to middle school and high school students, but it's not in the environment like this where it's a forum, or we've had things in the past where we've shown film or documentaries, but the kids don't gravitate to that. They want to be with each other in a non-invasive area where there might be tents and resources and tools available, but they're really with each other and they're hanging out and doing something. So we're working, Jody Jerome is a self-school teacher. She reached out and she has an affiliation with Doug and Danielle Flood. They are dairy parents, and tragically they lost their son in 2016 run the home pizza stop. And it's essentially concert events that they'll run in communities, and the kids sign up, and it's music contest. They put on a show, and then the kids come out to the show, but there are tents around the show that have mental health awareness promotion and resources and things like that. So the kids are there for a social event, but they're also just kind of congregating around and checking out these different areas and these professionals there to provide information or talk to them. And so I think it's a neat connection. So that's going to be a planned outreach. We also have internally some students that are organizing some events. May's Mental Health Awareness Month, so we're going to do a couple of things on campus that are going to bring our students out. This documentary, they also put a documentary, and they can share a trailer or send, if you have emails, we can send some information out. We've been working with our staff on this, and probably going to run their documentary in our library one night. And again, I think parents will probably love that. But as many resources as we can provide, we have to pay attention to the subject and devote time to. This is the first thing.
Yeah.
Just piggybacking off of you. They also have a student-led mental health group.
Yeah, I was gonna say, I thought they did. have
Yeah,
that.
my daughter signed up for that, and she loves it. I mean, she's a very type A person. COVID's just put her in a really odd headspace. She likes to be busy, very type A. COVID was the complete opposite of her, everything that she is. So this actually kind of brought her back a little bit because she felt like she was fixing, doing something. All right, let me get involved, let me do this, let me do that. So it's great if any of your kids want to try.
Yeah, because I noticed during the first hour of our DBT group, when it's just the kids together, it's like, then we get all together in the second hour, and I'm like, what happened? Oh, our parents are there, we can't talk.
Well, this is student-led, so I
So,
think
yeah.
that's a benefit.
Yeah.
There's, in your folder, there is a survey feedback form, so that if you wouldn't mind completing it, so that we can get more information on other topics that you may be interested in having us covered. Are there any other questions for Tori or Katie?
Thank you so much for coming out. Really appreciate it.
Thank you.